Good afternoon, George. It's Tuesday morning, and I'm in Manassas, Virginia, covering the office of a great friend of us and a Peds United fellow member, Brian. And we have
Yes.
a great guest today, Dr. Michael Martin, who's a dear friend of us.
Okay. And his topic today is going to be the different looks of independent pediatric practice and advocacy at the AAP level.
Welcome, Mike. How are you?
I'm good. Thanks for having me, guys. This is fun. I
Uh,
enjoy doing these.
It's a pleasure. So, Mike, why did you become a pediatrician?
Oh, geez. And 1 minute less. I
In
mean,
1 minute or less.
for me, it's a unique juxtaposition of things. I've always done stuff with kids, which I think every pediatrician said, right? I coached. I loved working with kids, and it really appealed to my analytic side too, and the love of science. And I played around in college with doing research and that path and just realized I'm a people person. I need to be up and moving and doing different things and having a job that I'm not sitting at a desk and I constantly changes and provides different opportunities. And so Peds was it. It's
Yeah.
very early on.
Now, you started your career in Northern Virginia with Dr. Schwartz, who's left us, right?
I did.
And you were there for 10 years. What was it like to work for Dr. Schwartz?
Yeah, it was, even right from the get-go, it was an interesting experience when I was even applying for the position. The common theme you'll see with me is I don't like to just settle doing one thing. I think you'll see that with a lot of entrepreneurs and practice owners. We need to have different things to dabble in. And there's no one that exemplified that more than Dr. Schwartz. And I remember meeting him. I was at a long, long week of interviews through Virginia, and he was my last one. And I just remember showing up and he was just electric and talking about all the different things he does in terms of teaching, the research. It was an instant connection. I was just like, this is someone, and especially after some of the interviews I had, I was like, I don't know if I can, the other places were really a right fit for me. And it just clicked right away. And I remember coming home, talking to my wife and she's like, how did it go? And I was like, think he offered me the jobs, but I'm not exactly sure.
He was a genius. I mean, he really was a genius.
He's yeah, big loss to pediatrics not being around, but he was a mentor to me. I mean, clinically, I learned so much from him, and he really let me explore my interests in a way that I don't think anyone else would. I remember even like about a year and so I'm only in practice a year. I'm still learning what I'm doing. I don't know what I'm doing, right? At 1 year out of training. The program at Inova needed someone to really run the continuity clinic, which was kind of a patchwork at that point. It had kind of fallen apart with a curriculum, didn't really have one. And so this great opportunity came up I got to know, just in that year, he kept bringing me to grand rounds and meeting people. And so they got to know me and were like, hey, we'd like you to take this to the program director position and really revamp the continuity, program. And obviously I had to go to my boss and say, I'm going to need some time to do this. How do you feel about this? And like, he didn't blink. He's like, you got to do it. I'm like, oh, okay. And I don't know many bosses that a year out that'd be like, that take you away from, generating and, revenue and seeing.
No, he
would let you do that.
What I remember about him is, he would shred people to pieces in those meetings. And then, the other thing I remember about him was his technique of cleaning the nose on the kids, fill the bulb syringe with saline water and squirt it, and then the mucus would go flying out the other.
Ears and noses need to be cleaned.
I always ask him, how do you stay in practice with all these bougie women out here in Northern Virginia? Don't they start hitting you when you do that? No, they're used to me and I'll do it. That was really fun. Why did you leave that practice? You were there for 10 years.
It was. I mean, it was an amazing experience. And I got to the part where I was really for me, I think I came to a path in the road where I just had very different vision for managing. And this is where I'm so grateful for him. Because I mean, during that time when I was there, I really got to stretch my legs and really get to learn how to run a practice and in some ways try different things out. I took business classes while I was there and he really kind of gave me the reins. But I think the largest thing, we just had very different visions of where the practice was going as we were getting larger. And so it was just a time, I think was the right time for me to leave at that point.
What were those differences?
You're getting into the tough questions now.
Yeah, because the differences of practice, that's like,
it's nothing. It wasn't the clinical stuff. It really had to do with how the practice runs, moving pieces of the puzzle in different places. So in terms of staffing, how we staffed, I had put together a pretty extensive business plan and was starting to initiate that. And, that with that comes unease, right? It's changed and people's roles are changing. And it's tough. I mean, I've been through different places where those kinds of changes occur, and I can see how it ruffles people's feathers, and that uncertainty is tough for folks, and you try to guide them through. But I think that is where some friction occurred. Rather than drive to further friction, it just seemed the right decision to step away, let him run things the way he saw fit.
Right.
Yeah.
I guess they didn't want to change and pivot. They just want to continue to coast.
Yeah. I think that's it's a disruption, right? And you have to suddenly, and it's just tough. It's like you've been doing things a certain way.
Yeah.
It's working. As we know, if you don't change,
I remember with my senior partner, when it was time for the EHR, he says, "Why do we want to do an EHR? It's been working like this for 30 years. So why would I want to put in EHR?" That's what they all do that because it's towards the end of their career. So why bother?
Well, I had a famous pediatrician tell me how bad computers were. And I did remind him that, at some point we were tasting urine to diagnose diabetes. He told me, that's a small price to pay to get rid of that machine.
That's funny.
He was kidding, but it was really funny. So then you've had tremendous success at Einstein's Pediatrics. And probably your wife, Day, is more successful than you are.
Oh, I would 100%.
Wow. How? And so for those people that don't know what Day did in her last business venture, what did she?
I'm super proud of her. So she had a path where she worked for other companies, a lot of startups, and got a sense of what that looked like. A lot of them went bust. So she saw failures. She had a back injury, actually. She had a car accident and had a back injury. And at that time it was hard for her to sit. So she needed a desk that would allow her to work at, but not sit, which now they're on every Target and every store, right? But she realized there was an opportunity there that at that time when she started, there weren't really standing desks. And so, that was where when she launched her own company, she started in our basement in our old house. That was our warehouse for a while. She actually works with my dad. My dad helped her design her first desk, which was really cool to see them work together. So he did some prototypes because he had carpentry skills. That's what's always funny. It's like Day's not an engineer. She's not, she had this company with, building furniture in the beginning, and that really wasn't her skill set. Her skill set was in analytics and marketing. It was very, very much kind of a stretch for her learning how to do production stuff. And the company took off. She was one of the first 3 really decent sized standing desk places in the US. She became kind of a darling of Amazon and spoke, I know, at a few big conferences they had invited her to Capitol Hill to speak on behalf of small businesses. Yeah, it was really cool.
And she sold the company for millions and millions, right?
Yep. I cannot disclose the amount, but she built the company up, and like a lot of entrepreneurs at that, she wasn't wanting to have a large company that she served as CEO. So she sold to a larger corporation, and
Nice.
Now she's right now she's helping me with my practice, but she's actually onto another entrepreneur. She's got another project she's working on now, which I can't disclose yet.
Okay. So how does her way of thinking influence the way you manage your pediatric office?
It was interesting. So when I started doing my business, when I started, at Advanced, started doing more of the business management side, I realized through her how important the marketing, and really marketing to me was just, it's another term for us motivating people to do good things for themselves. I mean, it's like people say marketing and they're, that's, you're selling stuff, you're trying to convince people of stuff they don't need. But I'm like, actually, it's motivational interviewing and how you present things to folks to motivate them to change and stuff. And a lot of what I learned through her was that piece of things. And certainly starting a business, getting the word out, learning how to, get people to know when I started my practice, where I was, what I was doing, and what was different about what we were doing was a piece of it. I still remember so she had a lot of experience with her business and taught me a lot about, just Google ads, really getting up on the high end of the lists and stuff. And at that time it was nobody was doing it. It actually was really, really cheap. I did not have to spend much money on the Google ads and stuff because no one was in the space at that time. Totally different now, but it's interesting. I definitely was able to get ahead on that piece compared to others where people just weren't occupying that space. And that was tremendously helpful.
Do you think there's a lot of pediatricians putting Google ads now?
There definitely, when I've looked, there's definitely more. I would say it's more the big hospital, because I was surprised the big hospital systems really weren't occupying that space yet either. And now they are. What I generally see is not necessarily smaller practices, but like more of the large practices and hospital systems putting stuff up now because they have the budgets, right? They have the marketing team, so they have the people doing that.
Yeah, in the old days, marketing was a bad word.
I still feel like when I talk to folks about it, I still feel people like, ew, that's not what we're about. I really look more at the psychology of what it is. You're doing something amazing in your office. You need people to come and experience that. It's good for their kids. They need to be vaccinated. And whether you want to use the word motivate or market, I mean, they're in many ways synonymous.
We get in front of ourselves as pediatricians. Look, we've been marketing since pediatrics has been a profession. And it used to be called the Yellow Book and the AAP directory. And then we went to the nursery and we brought cookies to the nursery nurses so that they liked us. And we were very polite to them so that they would send us patients.
You got it.
And then we played golf with the obstetricians, when that was a thing that doctors had time and money to do, because we would show up for the C-sections and they liked us. And then they would send us patients. And so we've been marketing since there was been a pediatric specialty. And, we need to make money in order to stay in business. So, money making is not a dirty word. And everything in life is a sale.
That's very weird. If you Google any physician, or most of the time the physicians, their name does not even appear with their practice. You'll get health grades, their name will appear with a hospital or US Health News, but their practice name does not appear almost ever.
It's hard to find them.
Yeah.
And those are the folks that don't realize that the importance of that stuff and that they're letting others kind of dictate how people view them, see them. And it's hard. I mean, it is another piece of what we do being added, another thing added to the pile.
Yeah.
But that's why you try to get a good team around you that can help you where your blind spots are, where you don't have the skills. You don't have to have all these skills. You just need to have people that do have those that can work with you.
Great. And then what is Trusted Doctors? What was the motivation to stand that group up?
Yeah. So Trusted Doctors is essentially the brainchild of Sandy Chung. People may have heard of her. President, right? I've been friends with Sandy, gosh, since 2006, 2007. When I first moved to the area, I got to know her real early and she brought me on as a board member at the local medical society in Northern Virginia. So we had she had been talking to me a long time about this idea of allowing for our practices to coexist and collaborate, but utilize our togetherness to negotiate better contracts, kind of share resources that are redundant that we all need. And so, out of that came Trusted Doctors. We have we call them divisions. What used to be our individual practices, they're technically Trusted Doctor divisions. We share a tax ID. Our billing goes through a central agent, a central part of the organization. And then, we're working together on clinical goals in terms of.
So it's very much practice without walls model.
Yeah. And that's but I think the important thing, and I think what Sandy I think a barrier, and I will tell you, Dr. Schwartz it definitely would have been a barrier for him, is that, that desire to continue to be autonomous and make decisions on the day to day and how you practice. And I think trusted doctors have stricken that nice balance. There are certain things that we certainly, and I think for most of us, it's the stuff that we know are important, but we're too much into the fine details of how our 401k is administered and the health plan stuff that, that we can all compromise on those things, but still at the practice level. The patients, when they walk in my practice, from the time before I was part of Trusted Doctors to after, I don't think they would be able to tell you the difference.
Right. And are you all an OP, or you can choose?
Yeah, so we've narrowed it down. There's two. So there's I think 3 of us are on OP. The rest are on eClinical.
Yeah. I hope you don't have to change the clinic.
So the plan is there's enough of us doing that. We have, in this where the billing side, we have enough billers that go around that some are experts in the OP and some in eClinical. And so the intention is now where the practices come in and have to make a choice between those two, though.
Okay. How do you do quality metrics? Because they're different.
So yeah, we do obviously some's going to come through the billing stuff, but we're actually doing a project called Fortify and we're actually part of the Children's Health Network in Northern Virginia as well, where that data is being put as well. We're building the capacities where this data is going to be de-identified and pooled.
Yeah.
And so we'll be able to look as a larger entity, what as well as what the divisions individually are doing. We have some of that now through the payers, but it's all payment based, right? It's all that, which isn't show everything. Right. But we're going to be sharing actually the clinical side as well.
What motivated you to run the Virginia chapter of the AAP?
My gullibility?
Yes.
No. It's funny you ask.
Who threw you in the pool while you were drunk?
Well, all things lead back to Sandy Chung. That's
okay.
I will tell you, in Northern Virginia, all things lead back. So Sandy's definitely in the mix of how I got to be there. It's funny. I will tell you, as a medical student resident, I did not engage in AAP stuff at all. So when I've gone back and some of my friends from then, they're like, they saw that I was, the chapter president, and they're like, you? Because they all were really engaged in it. And it's funny, I think close friends, I think I moved up the highest of all in terms of the organization. I think it was being on the management side and seeing how things, I'm a fixer. And I'm just like, this is ridiculous. Why does this happen? I think we've all asked those questions. And then and a lot of people just go on the way, well, that's the way it is. I'm just, I don't have time. I was like, no. I can't let things go. It's I need to start, I need to figure out a way to work on this stuff. And then overlapping with that was sort of Sandy bringing me in locally on stuff. Then I became a delegate for the MSV, or Medical Society of Virginia, which wasn't a good fit for me. It just the way the organization ran. I didn't find a home. And then Sandy had already moved over to the chapter. And it's you should come check this out, what we're doing. And so I became the Northern Virginia representative, and I was like, oh, this is great. I mean, they were working on stuff on the payment side. They had some great immunization projects going. I mean, and the people were just, I connected with. Right. So much so, I mean, even I remember when I started the person that did a lot of work on the payment side, I had some issues early on, and they were able to step in and make connections for me and saved me, I'm not exaggerating, at least $30,000, probably closer to $40,000 that I would have lost. And so, I mean, that alone, I was like, I've got to, I have to contribute to an organization that's helped me so much. And so I just felt it was my responsibility. So much has been given to me, Dr. Schwartz, the chapter, and it was time to get back for me. And so, yeah, I just kind of worked up the chain at that point.
What do you think was your biggest win while you were president of the chapter?
So when I went in as chapter president, you all recall there was no COVID right before I was getting prepped and ready. And then as I was getting closer, COVID came. So I had this huge agenda. It's going to do. Out the window that went. And I honestly think I'm probably the right person for it. I think looking back, I'm pretty flexible. I'll bounce with things. And And that was COVID for 2 years, right? It
Yep.
was just in making constant pivots and adjustments. And I'm a pretty open person to change and hearing different perspectives, even when I go into a pretty hard stance. I think for me was just doing that pivoting and at each step identifying the needs for the pediatricians in Virginia. I mean, the earliest thing I remember doing is we like getting masks, getting just face masks, getting supplies that people couldn't get. And I saw someone doing it at a local level. I'm like, why don't we just do this at the state? We kind of had 5 regions. I started to set things up and take orders from people and started collecting stuff to the point I couldn't even accept all the stuff. There was a company that was trying to give us, I can't even remember, like 3 or 4 truckloads of stuff, but I had nowhere to put it.
Oh, well.
It was a good problem. But I think it was that. I mean, I think for us, at each step, something new was occurring and responding to it, really utilizing effectively communication, multi-channel communications with folks. So, we started listservs at that point regionally. I did some live stuff like this, some podcast type stuff, really. And then I think we ended up running 30 plus different webinars and things, and really putting those pieces in place. I think all of that was because of COVID and as things change and the needs that were happening.
You did a great job. I mean, people are very happy with what you did.
In the middle of it, you're like, oh my God, I hope this is making a difference, right? You're like, I was probably working 90 hours a week. I was working, Saturday and Sunday was for catch up.
Yeah. No, you did a phenomenal job. Everybody says you did a phenomenal job. Thank you for that.
I'm hoping I helped. I mean, I hope I made it a little bit.
And you also pushed across the goal line Medicaid reimbursement, right?
Yeah.
You didn't get to 100% of Medicare, but you got it from 50 to
we keep pushing. I mean, that battle happened before me and will continue. That's been a target of the chapter for a long time, and we'll keep pushing.
Why is that? Why is that important?
It's one of the huge barriers to providers even taking Medicaid. I mean, even our region, we don't have it. I mean, honestly, across the state, we don't have enough people taking it. And understandably, the reimbursement is so much less. It's getting harder and harder. Those margins are getting leaner and leaner. So, I see places like, the Innova Cares Clinic that can't run in the clear because they're not being paid for what they do. And while Innova can absorb that, those of us in private practice can't.
So we need to make money to pay rent. We need to make money to pay our mortgage. We need to make money to treat our staff properly. And if we don't, if we're losing money, we won't serve anyone.
No, and we can't hire good people. We can't. I mean, it just tumbles in, and you guys probably know this, but I mean, we're headed towards troubled waters ahead with having enough providers, staff in primary care in general, not just pediatrics, but primary care. And I mean, we're headed over the ledge, and I'm not.
I know. Here's my own soapbox on this. What are your thoughts on student loan forgiveness? Because you, as a private physician, your office is not designated as an underserved area. You may be servicing a lot of Medicaid and Child Health Plus, medically underserved population, yet nobody cares. And across the street could be the Novo Health Center that bought up Dr. Bravo's little practice, and all of a sudden that practice is an underserved area, and then they could get loan forgiveness in that office.
Yeah. Oh, I think it's a great tool. And when we're doing go back to my chapter hat on the executive board, one of the things that we're constantly seeing is encroachment of scope of practice. And it's always driven by access. And it's like, this is the kind of tool, if you want people to go to a particular area, Southwest Virginia, this is the perfect tool to get people down there. But what we keep doing is giving non-physicians privileges to do other things that not necessarily trained to do out of that desire for access. And then they're not going to those regions. Right. That's my favorite part of this.
That's the second soapbox.
So that's another, but the honest truth is there are many counties in the U.S. that do not have a pediatrician, period.
Right.
And there are very, very many areas, even in Northern Virginia, where access is very limited to a pediatrician. And I think we are over. I think we're over the cliff. This is do change now, or we are in deep trouble.
Yeah, you can't just pull this out of that. The only thing, and this is my fear, is that we're creating the gap's going to keep getting wider, and so you're not going to have doctors to pull from. They're going to start giving others the same privileges.
I had a discussion. I had a dialogue today with somebody at the AAP level in the advocacy, and basically talking about the underserved areas and medically underserved populations. And I told them, I said, listen, my office has 20,000 patients, 65 of which 65% Medicaid and Child Health Plus. We have like 15, 16 doctors. This year alone, we had 4 candidates that we could have recruited that came to our office as children. We saw them when they were born. Perfect candidates, right? For a great story coming home. They went down the street to a federally qualified health center or the non-for-profit, literally a half a mile away, servicing the same population of people because they had student loans. They couldn't come to us for that because of that reason. Now, you know what was amazing to me when they stated to me was, well, Dr. Rogel, you seem to be the only one complaining about this. That's weird, right?
Well,
terrible, actually.
I want to get away from this means testing. We don't means test public schooling in America. So we have already a shortage of primary care doctors. Try to see an adult endocrinologist for your type 2 diabetes. It's a 6-month wait.
Yep.
Okay. Even if you have insurance, if you have wanted to pay cash, it's like, can't help you. I'm booked for 6 months. I can only see as an endocrinologist 10 patients a day. Each patient's 45 minutes.
Yep.
And so let's stop talking about Medicaid and let's stop about CHIP and this and that. Every child deserves to have a pediatrician in every county. If you go into community pediatrics and you're community based, whether you're employed by RBK Pediatrics, Einstein's Pediatrics, you're independent contractor like I am, there should be loan forgiveness because we need access to pediatric care for everybody. The white kid, the black kid, the brown kid, the yellow kid, the tall kid, the short kid, the gay kid, the heterosexual kid, the boys, the girls, they all deserve. There is no means testing, just like they all deserve primary and high school education.
Well, that's wishful thinking, Herb. That's really wishful thinking. You
No,
might be able to get, you might be able to get something with Medicaid and Child Health Plus because these are all federally, programs.
Right.
But, I made the person realize that my office is located it's not an underserved area. It's not a rural area. But if I can't hire doctors and the office starts to dwindle and we close, the 20,000 patients that we service, 21,000 patients that we have, all of a sudden we'll have no doctor. And then you know what? Comac will become a medically underserved area.
And then, I'm old enough to remember when we didn't get paid for the vaccines. And we would do the well child exam and then send the patient to the health department where the nurse would give the vaccine. And if we do not value pediatricians, if we do not address their student debt, and we don't pay them enough to stay in business, we're going to go back to the point where children don't get well child exams. They go to the health department, they get vaccinated, and that's all the care they get.
Yep.
And that is not what we want for America. That is not going to produce a strong democracy. It is not going to produce a strong country. So I need all pediatricians to stop talking about Medicaid and start saying we need to be paid fairly, and we need to be paid fairly today. And every child without means testing needs access to a residency trained pediatrician. That is what's fair. That's equitable. That's inclusive.
Yeah.
That's DEI. Let's just stop with the nonsense.
Yeah.
That's really what we should be all saying together, arms in arms.
Yeah. I wishful thinking, Herb.
Well, George, if we don't dream, it will not happen.
I think we do have to start and I think at the national, I think we are attempting to be louder with that message because more small, I will say there's a shift in what in practice we're seeing as well. I mean, we're definitely doing more complex things because of the limitations. I mean, in Northern Virginia, we've got 2 hospital systems, 2 children's hospitals. And like you're saying, there's a way, I mean,
Yeah.
for multiple
neurologist. You
specialties.
can't see a neurologist. Psychiatrist in Northern Virginia is 2 years wait.
Yeah. There's definitely more incumbent on us as pediatricians for managing than there was when I started. And I just don't I don't see how you do that without more. I mean, if it's that workforce has to come from somewhere that has some training in this stuff. I mean, I probably see a quarter to a third of my day is mental health now.
Yeah.
And that takes some skill. I mean, that's not, I'm starting to get my younger physicians trained to do that, but it takes skill and time. And it's just blocking our schedules up more as we take on.
Even with the mental health, if you're a mental health center or behavioral health center, developmental center, you're qualified for loan forgiveness. Yes. But Dr. Martin, you're just a pediatrician.
That's right.
Who cares? Nobody cares about Dr. Rogu and Dr. Martin.
Yep. And then, we need to change that. Obesity is a big problem. It's very time consuming. It's very important.
Yeah.
I joke with my radiologist friends that, through most of my career, I never ordered an MRI because if a kid has a weird headache or post-concussion symptoms, I would send them to a neurologist first. But now,
no one would order the MRI.
But at least they would know when to and when not to.
They order on everybody.
But nowadays, it's like I can't get them to see the neurologist. So I'll order the MRI and treat their migraines, with Zofran and Motrin until they can get an appointment.
Yeah, no, there's a lot of we're doing to patch the time, and that's where I'm more and more I'm taking on more complex stuff that I'm like, there's a discomfort with what I'm doing, but I've got to do what I've got to. I mean, somebody, if I don't, then who will?
No one will.
That's part of our problem sometimes in pediatrics is that we're always wanting to help and we overextend ourselves. I think we're givers, and that's where I think on the advocacy side there are times we have to be like, enough's enough. I'm not doing and we have to, and we just, part of this I do very much strongly feel it has to come not just from us, but from those we serve, the families, and they're the voters, and they're the people who have to push back to that. Just us, and we're a relatively small group, but I think when everyone starts to feel the pain, we have to educate them on why that's happening.
Yes. And so I think at the chapter level, the AAP has done a phenomenal job of advocating for pediatricians.
Yeah, I'm always amazed how much I have to tell you a little bit funny story. My nurse practitioner was in the office in the middle of all this COVID stuff, and I probably looked 20 years older and sleep deprived. And she's like, Dr. Martin, I hope they pay you a lot of money for doing this. It just laughed. It's like, she's like, what? I'm like, we don't get paid for all volunteers.
Right.
There's no money.
I don't know if there's a communication gap at the Chicago AAP, but it really does not feel that they have my back as a practicing pediatrician at the Chicago AAP. And I think that needs to be changed, because without pediatricians, there are no healthy children. Without healthy children, we don't have a country, So it's like what I tell the mothers in the exam room over and over again. In case of an emergency, put the oxygen mask on your face first, then take care of the child. Because without a mom, I can't take care of the kid.
I'll tell you.
Think about it. Without pediatricians, what will happen next? There'll be no more AAP because there'll be no more members.
Well, there won't be a society because children need to be healthy and cared for. We don't want them just to get shots at the health department from a nurse that can't do developmental screening, that can't address their mental health needs. But what are your thoughts?
Yeah, so I have to tell you, so they've gotten this, I got it at the chapter 2 where people didn't feel we represented them. This was, I feel like we're in a better place now, but you still get some of that. I think we made some inroads in it. And I get the disconnect that pediatricians feel with the national organization that happens. I think for the chapter, I will definitely say, and I think national is a victim of this. I think sometimes there's not enough communication to let you know what's being done. And there's a lot of things done behind closed doors, and being like, when we were doing advocacy stuff, I don't think people knew. And that when I joined the board, I do remember, and that was a real push for us to start being better about how we communicate and really pushing that out and engaging folks in discussions about what they wanted us to do. And so I do think of the chapter, we made a very mindful effort, and I think COVID helped even accelerate that. I think there are efforts at national in recognition of that disconnect, because I do think there's, like a lot of these people you've had on here to interview, there's amazing people doing work on our behalf that are doing stuff that I think the majority of people don't even know they're doing.
Right.
Their story needs to be told.
Their story needs to be told. And
Yes.
I think figuring out how to best do that, I always say, in medicine, this was one of the things, we're always behind 15 years of business practices, in terms of how we run our practices. It's really fascinating to see, but I think that carries over to some of our organizational stuff too.
Yes.
There's that it runs a little bit like an organization did 10, 15 years ago.
Well, no, the AAP runs like
More than that.
Okay, I'm being nice. Let's go work with these people.
So you got Click and Clack over here, two knucklehead doctors that figured out how to elevate pediatricians. Very difficult.
With a zero budget.
With a zero budget.
No, but here, I don't think the AAP has realized yet that Monkey Survey can survey 60,000 people with one button, and you can ignore the feedback, right? I mean, say the obesity guidelines, right? You could have put it out to the 60,000 pediatricians for a review and given them 48 hours to look at it, and on a Survey Monkey say, you think this is doable at your wherever you are, like private practice, hospital, academia, and, gotten a report back. You might choose to ignore the report, but now people felt hurt.
Yeah.
Right. And it's Monkey Survey. It's $230 a year for 10,000.
And there were a lot of different ways, right? You could have seen organizations where they, there's all these conferences across states and stuff where this stuff could have been presented there. Here are some of the things we're working on.
Right.
Looking for, there's different ways one could do that.
To do it. But I'm just saying, you want to do it cheap. You want to reach everybody. Yeah. It's called Monkey Survey. Yeah. And that's been around for years.
Yep. No, I get you.
Right. Yep. So I think that's where you feel that disconnect. I don't know who they are. I don't even know who the board members are. I
think it's interesting what you're saying, because I think in a lot of ways they did it the other way. They put a lot of time once it was out in getting and discussing what it meant, right? And telling you why they did what they did, making it a little more transparent on the formation part, things working on, including it's a different model. It's
the old model. And I totally understand it, because I grew up in the time that if you wanted to go read a journal, you had to be affiliated with a medical center and go to the medical, the medical library, the big hospital.
Yeah.
And they had all the journals, and, they could pull them out and you photocopy it and you take it home. We don't need that anymore. We don't need a huge library in Chicago with all the textbooks, and it's called Up to Date. It's called Google. It's called Bing. And, for $15, $25, I can download any MedPlus, any article I want, read it, and figure it out. So we are no longer bastions of walled off knowledge that we used to be before the internet came. And the internet came before 2000.
Don't forget, internet's old. It's ChatGPT now. You just tell ChatGPT what you want and it'll pull it for you.
Yeah, George loves ChatGPT. I think it's such a good thing.
It works.
It does.
There is going to be a place for ChatGPT 4, not 3, in healthcare, and some people are already working on that. It's called Carbon, for example, and they really will create your note from listening into what you're doing.
100%. That's the direction. It's so great. Yes. We're database entry right now.
Yes. Yeah.
Right. It doesn't make any sense.
Talk about poor management, right? You get the person that makes the most income for the company, the most revenue, the most highly trained, and you turn them into a data entry clerk.
Right. Yeah, no, it's
Genius.
never made sense.
That was genius.
Yeah.
That was genius. This is genius. And I'm not going to say who did that to us because I get in trouble, but that was a genius idea.
I look at it, it's going to be a very small piece of history. And it really was just, it's going to be a very, I mean, I knew it was be this direct. I knew this was a temporary thing. And this is the technology that's going to, I mean, the people who need to be worried are actually, and I'm happy because they drive me nuts, is the EHR companies.
Yeah.
They wanted to like charge us for this and that. And the AI is going to take a lot of what they do away from them. You're not going to need it, right?
Yeah.
Well, I'm using ChatGPT within my EHR where I tell it, write me a history of illness for a child with a sore throat. It writes me some words, a paragraph. I fix it up a little bit because it's never good. And then I drop it into these phrase construction places and I talk to the patient. I know what I'm going to ask. Whoop, put that button. I got a paragraph.
Yeah. No,
I've even used it on some rebuttal letters for insurance negotiations. You know, when I was big on the COVID testing and I went into ChatGPT, I said, write me a rebuttal letter to the evil empire about not covering COVID testing or whatever. Oh my God, you want to cry after that. How could you not cover COVID testing on little poor children?
Yep. So Mike, what challenges do you still think that we face as a profession right now? Like top of the line?
There's a long list. I hate to say it that way. I want to start by saying I still love what I do. I think it's an amazing thing that we
still
do.
love what we do.
Yeah. I mean, I still love it because that's where I look, you know, I'm sort of at that middle age, right? Where everyone starts to question and they get their sports and they question their decisions they've made. I have no doubts that pediatrics was the right decision and I'm grateful for it every day I go to work.
You're a rock star.
No, it's just a fun field. Where else can you go in? You smile, the kids, I mean, it's a happy place.
Yeah, it's definitely the best job in the world.
It brings joy and it's important. That's the other thing. This is the conversation I always have with my wife because it's like, she can make so much more money than me, but I'm like, I'm doing more important work.
You
are.
You're
not going to show this to her, right?
No, I would not say that to my wife.
So challenges. I think insurance piece is just always is the big bear in the room, and the margins are getting tighter, and we have to, you know, you can only run things ever so more efficiently, and so that has not been fixed by anything. And so I still think on the payment side is still one of the biggest things for us is getting recognition for what we do. I look at other countries, the dollars they put into primary care, whereas our country inverts it and puts it into all the specialty care.
Right.
And I'm like, and one of many reasons our outcomes aren't as good because we let there become problems that need fixing rather than prevent problems. But unfortunately in the models, you know, and this is where I think AP is definitely doing work is looking at guides as to what's important and what should be rewarded in the payment system. That's going to lead to good outcomes for kids. And that's always, that's the challenge is the insurance company looks 2 years ahead. We need to be looking 30 to 40.
20, yeah.
Right. And so that to me is really where a lot of change is happening. And I think we're making headway in getting them at the table and having pediatricians decide what those should be, but still a lot of challenges with that.
I think you're right. I think the financing of healthcare where we cheat the kids and we underinvest in their health and their well-being, it's really costing us a tremendous amount. So Kaiser Permanente has a study that says the average Medicaid child spends $2,000 a year, while the elderly is spending $13,000 to $15,000 a year on Medicaid.
Right.
And but all the time we hear, well, you had this many preventable ER visits, and you had this many preventable hospitalizations, and you wrote for this brand name only here that cost this much money. Are you kidding me? These kids costing $2,000 a year. How much leaner do you think we can get?
And I have to tell you, it's crazy. We have one of our payers is wanting to decrease us 8%. And with inflation, our costs going up, they want to decrease what they're paying us 8%.
How is that a good idea?
I'm like, and I'm just like, that's exactly it. I'm like, how much more are you gonna squeeze out?
You know where that's coming. I don't think Innova's doing this, but you know where they are doing it in Long Island. You know where that's coming is you check into the ER today, you get the multi-respiratory panel screen. That's $1,200. So that, that's going out of their margin. So they're looking for, someone to take a haircut.
Yeah.
And the pediatricians are the easy haircut.
Because you're not going to complain. You're going to say, thank you.
And so that's the message.
Yes.
You have to complain and you have to, and this is where it's hard, but going toe to toe and we're not going to take your insurance then.
Yes.
Well, that's
the only leverage you have.
George, I think sometimes it is like there's some managed care Medicaid plans that pay, like 50% of what regular Medicaid pays. And people still take them.
They don't even know they're taking them.
So no, okay, I'm not going to take that because this other managed care Medicaid is paying me 2 times as much as you're paying me for the same work. Sorry.
Yeah.
And those patients will switch over to the other Medicaid plan.
Well, that power you do have to guide them into a different plan. You can call the ones that pay more to come in for their routine checkups. And ultimately, this company will have poor HEDIS measures, and they'll have poor reports and poor quality and so forth and so on.
Yeah.
But those guys usually don't care about pediatrics. That's why they do that.
Well, then fine. Then, then
they have to have it. They have to have a pediatric presence.
Yeah. But if people put their big boys' pants on or skirts or whatever they put on, below the waist, and they tighten their belt and they go, I'm not going to put up with it. And 90% of the pediatricians in Virginia will not take plan number X because of unfair reimbursement practices. Guess what? Things will change.
Well, that's where the problem comes in.
But if we're wimps and we don't do anything.
You can't do that because of regulations.
There is no regulation.
Well, you're unionizing doctors. You're mobilizing doctors. You're organizing doctors against the company.
No.
Yes, it's a problem.
It's not a problem to say Medicare fee schedule is $100 for 99213. Say, I don't know what it is right now, but say, if a payer gives you less than 50% for 99213 compared to Medicare, then you should not participate in that plan. There's nothing illegal about that.
No, there's nothing illegal about that. What the legality is, you convincing Dr. Martin and myself to not.
Okay, well, that's different. If I was talking specifically about the evil empire, and and to the two of you in a closed room, when we were all within a 3-mile radius, and we all agreed to dump the evil empire in the same week, yes. But to educate pediatricians to say, if someone's paying you 50% of Medicare, you cannot make money. Drop that plan.
Yeah, you can't.
Drop that plan. Do the community a service. Drop the plan. Because that will send a strong message, and the people will move over to another insurance company, or they will change their ways because they need access to pediatricians.
Yes.
But
I do think strongly that's the answer. I agree. Like, we can't all get in a room and discuss this stuff. But if we all, as a general rule, are not letting ourselves let plans take advantage of us, it's going to disseminate, right? I mean, it's multiple people doing this. And, I think at the end of the day, it's like, the truth is, like, we're in areas where there's not enough pediatricians, and you do that, they're going to have to deal with us. Yes. Because there's not enough of us.
And if that happens, it'll become a medically underserved area, and then you can get your loan forgiveness.
True.
We all get what we want. See, I knew we could. Everyone's happy.
So I'm always happy when I like being grumpy and cynical. And then I hear your laughter, and I'm like, well, what could be better?
But this is all really important stuff, and I think this is, as individuals, our voice doesn't carry as much. Certainly say no to insurance plan, but this is the stuff that the AP, we need them for.
Right.
And we have to have, like, we need someone sitting at the big boys table with the big plans and the leadership in those plans and having these discussions like, this doesn't make sense. This has to change.
And we do need a union, and it's not illegal to unionize as long as you're an employee physician.
Right.
If you're employed, you could be unionized. You just can't be employed unionized and be the owner of the business, you know? And if the AAP doesn't change its communication skills and doesn't have the right leadership, a union's coming because more and more physicians are fed up of the working conditions, and the reimbursement. And, physicians are very unhappy. They're burning out and they're quitting mid-career.
Yeah. Now, that's been, I will say, having gone through COVID, but pre-post, that's been the scariest thing for me, is just seeing the overall morale.
Yeah.
It's really down.
The morale is down. The applicants are down. Heck, we're using 3 headhunter corporations and we can't locate a candidate.
Yeah.
3. It's not like you call them residency programs.
Yeah.
No,
it's
a shortage is here. The shortage is here.
Yeah.
And it's,
I mean, that's the thing. It's already here, but it's going to get worse. And that's
Yes.
like, you're not seeing mobilization, and you're kind of like,
yes. And you know what's worse is that I'm a little bit older than you,
yeah,
like by about a decade. And so I'm more likely to start getting sick and needing an internist. And there's none of them.
Yeah.
You can't find an internist. They're all working.
it's hard.
They all work at 12-hour shifts at the hospital for $350, and they're on a week, off a week, on a week, and they love their lives.
No, they don't. I have a lot of friends at hospitals. They don't love their lives.
Well, it's better than the internist, that's not making any money and seeing all these complex patients,
Yeah.
in a little, 2-person office, and is sweating how they're going to pay for, their staff this week. Well, I don't want that for the kids.
Yeah, that's going to happen.
No, it's not. You're being like, who.
Well, you know what? I am starting to get drained. Our line was primary care when you wanted, urgent care when you needed, services provided by physicians. Great line, right? Great practice. Because we're having this crunch, I gave in and it killed me to hiring NPs.
But
you don't have anybody yet. We didn't do it, but we're starting to look.
But you didn't find the candidates that you thought you were comfortable with.
Well, they all went to the system.
Okay. Well, no, I'm not nurse practitioners. None of them were experienced.
Oh, no, those guys, none of them were experienced. They were fresh grads. I'm going to have a 22-year-old taking care of a meningitis or something? No, thank you.
And so, but what I think the future payment has to be addressed. The way we are treated as human beings has to be changed. That has to be front and center at the AAP in Chicago. It has been front and center at the AAP at the state level, but not at the AAP in Chicago. We need a leader that will put that front and center, because the shortage is here, the crisis is now, and the change needs to happen now. But I do think, because I'm an optimistic after 2 bourbons, that
where's mine? I didn't see.
I know. I'm still in Brian's office. I can't.
I think we got to get Dr. Bravo to be the AAP president of Virginia.
Oh no!
We got to get me to be the AAP president of New York.
No, my God, no! I'm not a good politician. I tell people what I think, and in their face. And
that's why I got to tell you, I'm the same. I'm pretty direct. I think people in my practice get I cut to the chase. So we have a lobbyist at the chapter, hugely important. But I had to get there was a number of text messages sent to me to keep me preemptively. Don't say.
Stick to the talking point. Yeah. But no, I think that, as you alluded, and I am going to be political. The Obama administration was snickered or poorly advised into foisting the cash register in front of the American physician. That system was not ready for prime time. It was a waste of money. But I do think that we're at the brink of where artificial intelligence, natural language processing is going to make that system usable. And it's going to make us more efficient.
Yeah.
And where I see the change coming, which is going to be difficult for us older physicians, is that instead of nurse practitioners and physician assistants, which are also expensive, they gather good salaries. We're going to move to a more team-based approach where we're going to have LPNs that are particularly trained in development, LPNs that are particularly trained in, patient safety, LPNs that are particularly trained in diet and nutrition.
Well, this is all nursing work anyway.
And they're going to do all that heavy lifting and maybe even mental health. I mean, cognitive behavioral therapy is not rocket science as long as somebody teaches you how to do it and you have the time to do it. And so we might be seeing 50 patients like Nola is doing in Alabama, but we're not going to be doing the work that is way below our level of, training. So the nurse will come, she'll do the weight, she'll tell the parent the weight's good, it's not good, the BMI is this is nutritious thing. The other nurse will come in, do the development, the other nurse will come in, do the safety stuff for the kid. When I come into the room, I'm going to talk about what's important to the parent and what gaps the nurses have identified for me. And then I'll go on to the next room.
And then everybody's going to say you're not doing nothing and everybody else did your job.
That's the way it works. That's the way the world works.
I'm envisioning, and this may be unique to my region, that after that happen, patients, the parents are going to ask me all the same stuff again.
It's quite possible. It's quite possible. But you know what I mean? If all this, I don't need to score another ASQ3. A staff member can.
I agree with you. I think these sort of redundant tasks, 100%. But I do think it's, at least in the population I serve, I'm like, they're not ready for it either. They're going to have to be brought into it too, because
that's when you go, if you want me to be doing all this, my concierge fee is $3,000.
Right.
And then I'll spend an hour with you. You'll see even in Northern Virginia where they're driving the huge Escalades that are $100,000. As soon as you say it's $3,000 per kid, they go like, well, we'll go through the normal process. Thank you.
Oh, they do. It's like the after hours calls we do, like at my practice, we do put a fee on it just to cut down the volume.
Yes.
I had a mom call 20 times in 2 months after hours and never came in for a visit, just used it as a.
Yes. Oh, this is ridiculous. What else do you want to share with the national audience that I haven't asked you?
Yeah, I mean, for me, we're talking about the changes you want in national AP stuff at the chapter. Like I said, there's no money in it. I'm sorry. It's pediatrics, right? But we need people. I mean, and it can be small, it can be big. We have, if there's things that you're seeing and that you, especially an interest and expertise in, it's like, there's a place for you. And I know I'm doing a lot, working with residents and medical students, kind of bringing them up in that culture. It's like, you need to engage. Like I didn't at that stage. I just didn't understand the value of it. Now being out, I'm like, you determine your future, and and you can be on the sidelines, or you can be in the middle of it and being a part of making the changes. And it's that simple. And I know it feels like at times it's heavy lift. You're not getting heard, but I can tell you, having done this for, I guess it's been 15 years, it does make a difference. It's just not as fast as any of us want it to be.
Yeah.
But I can tell you, when we're not at the table, it goes very badly.
Yes. Yes.
It goes much worse.
Absolutely. Well, Mike, it's always nice chatting with you. I'm glad you had time to do this for us.
No, this is fun.
Yeah.
And hopefully you'll be at NC this year, I hope.
Yeah, it's right in DC.
Yes.
How could I not? It's like,
I don't
down
know.
the road.
Maybe you're like,
I'll definitely be there.
So hopefully we'll get to catch up with you there.
Absolutely, guys.
Well, thank you for your time. This has been very entertaining.
Good time too. Thanks a lot for inviting me.
All right.